Hello everyone, welcome to yours and my favorite part of the week. That's right, it's your online developmental psychology course, and I'm here to walk you through our final chapter in our final lecture together, and that is Death and Dying. Before I jump into it, I want to thank everyone for all your hard work this semester. I know that this semester was particularly challenging for obvious reasons, and hopefully the format of this class helped you, or at least reduce the amount of stress you had for this course, that is weighing discussion post much higher than typical courses, and the weekly feedback. So again, thank you all so much for your work and your effort this semester. With that said, let's jump into it. Okay, let's begin this chapter by defining our terms. And obviously for this chapter, we're going to begin by defining death, and beginning with biological death. It is not a single event, but a complex process. Different systems of the body die at different rates. Some people who have stopped breathing or lack a heartbeat would have been declared dead in another historical period can now be revived. Life support machines can be used to keep blood circulation going, even when there is non-independently functioning heart. The Harvard Medical School in 1968 defined biological death as total brain death, irreversible loss of functioning in the entire brain. Higher centers involved in conscious awareness and lower centers that control basic life processes. So you can see here kind of an example of the historical era having an impact on the definition of death, on literally how we conceive death. And that is with the advances in technology, wherein medical technology can keep a patient's blood circulation going when in other historical eras that person would have died, because that machine is not available, obviously, to keep that blood circulation going in the body. So you can see here, as stated, historical era effect on the definition of death. And then, as stated by Harvard Law School, kind of the idea is irreversible loss of functioning in the brain, and how it's typically categorized is that lower centers of the brain, such as like the brainstem, for example, control kind of what it means to just have any basic life processes, while something like the prefrontal cortex, for example, is one example of higher centers involved in conscious awareness of the brain. And the idea here is that the entire brain is both higher and lower, have irreversible loss, but obviously this is just one definition, which took place in 1968, and as I stated, they change, and obviously there are competing theories of what biological death entails. The American Academy of Neurology categorized or qualifications to be judged death are be totally unresponsive to stimuli, including painful ones, fail to move for 1 hour or fail to breathe for 3 minutes after being removed from a ventilator, no reflexes, and no electricity in the brain. So again, we have a different competing idea of what death means, and you can see to the left-hand side different neural imaging images that demonstrate the differences between a healthy control brain, a brain-dead brain, and vegetative state brain. Continuing on with defining terms, euthanasia is, quote, happy or, quote, good death that usually refers to hastening the death of someone suffering from an incurable illness or injury. Active euthanasia, also known as a mercy killing, deliberately and directly causing a person's death, administering a lethal dose of drugs to a pain-racked patient in the late stages of cancer. Passive euthanasia, withholding extraordinary life-saving treatment, allowing a terminally ill person to die of natural causes, withholding extraordinary life-saving treatments, a feeding tube. Assisted suicide, making available to a person who wishes to die the means by which she may do so. A doctor's writing a prescription for sleeping pills at the request of a terminally ill patient who expresses a desire to die. So our differences in terms here are active versus passive. Active, wherein the medical professional is taking, straightforward an active role in the euthanasia process, versus more of a passive role, wherein something's kind of taken away from that individual. So removing a feeding tube or some kind of treatment that keeps a patient technically alive. So it's one is taking an active role, one's more kind of a withholding or removing something that is maintaining the life of an individual. And assisted suicide, as stated, is kind of the idea here is that you either prescribe some kind of medication that at the request of a patient who wishes to die. And for the purpose of this class, they can be best conceptualized as a form of active euthanasia. Death is also a psychological and social process. Aries argues social meanings of death have changed over the course of history. Since the late 19th century, Western societies have engaged in a denial of death, have taken death out of homes and into hospital/funeral homes. There are less direct experiences with it than our ancestors had. And this could be related to many reasons. This is coinciding with the Industrial Revolution in Western societies. And the idea could be that kind of as those cultural practices reflecting kind of economic changes developed, where you're pursuing your individual pursuits to kind of a limitless potential, and also kind of limitless opportunities for kind of like wealth accumulation. Death kind of represents a finality of that and kind of a direct contradiction in that pursuit. So kind of like alongside of people living kind of their historical places where they live to kind of go into the city to participate in kind of industrial capitalism, leaving behind kind of those more community-based practices. The fact that an international community of doctors exists, there still is much cultural variability in how doctors view health and physical ailments, because doctors are trained within their own culture and so are products of their culture. This is particularly the case when we consider the metaphors with which doctors explain and understand the human body. In China, the metaphor of yin and yang emphasizes opposite forces in balance. Imbalances are believed to lead to illnesses. Imbalance can be corrected with acupuncture, herbal medicines, exercise, diet, and lifestyle. In France, the metaphor of the body is terrain, translated roughly into constitution or resistance, which emphasizes a sense of balance as the key to good health by supporting the immune system. French doctors prescribe fewer drugs, but more vitamins, long rests, and spa visits. Dirt and germs can strengthen one's terrain, thus there is less emphasis on daily bathing. U.S. metaphor of the body is a machine that needs to be tended regularly to make sure it's running well. If something is wrong with the body, then doctors fix that part of the body in the same way that a machine is repaired. American doctors are more likely to use surgery to fix, remove, replace, or change different parts of the body. Germs are a key threat to health, and people should avoid germs to be healthy. Thus, doctors prescribe antibiotics at higher doses compared to other countries. So kind of the idea here is that how you understand yourself, how you understand your connection to others around you, other people, and kind of just the world around you more globally, informs. Those are impacted by cultures, and obviously those culture understandings of those said kind of components of existing in the world impacts medical professional practices. And so as stated, you can see in the United States kind of visualizing or the metaphor of choice being kind of this idea of a machine where kind of a damage to the machine, then you repair the machine, and then you're back to business. And this kind of reflecting this very biologically based asocial understanding of kind of just operating in the world and the individual's culture, but also reflected in kind of medical treatments as well. And you can see even in Western cultures, as stated in France, there are different levels of drug prescription, willingness to do particular surgeries, and even kind of like approaches to dirt and stuff like that, found across different cultures in the West and in the East. Continuing on in cultural variation and grieving, there is no one universal way to grieve. Funerals are on occasion for avoiding people or holding parties, for fighting or having sexual orgies, for weeping or laughing, in 1,000 different combinations. Mexican American mourners do more viewing, touching, and kissing of the deceased than white Americans. Black Americans tend to regard the funeral as a forum for expressing grief. Japanese Americans are socialized to restrain their grief, to smile, so as to not burden others with their pain. Irish Americans have traditionally believed that the dead deserve a good send-off, a wake with food, drink, and jokes, the kind of party the deceased might have enjoyed. So, kind of as stated, there's just different cultural understandings of the purpose of funerals or kind of just memorial services in general, and different approaches that people take when interacting within that social scenario, and kind of just really even the design of that funeral or remembrance process. And these grieving processes are consistent with other kind of cultural practices. So for a kind of example, you can see Japanese Americans still having similar levels of visual expression of their feelings, and in this case, in the process of grieving. So kind of in general, as we've spoken on in previous chapters, kind of a higher willingness to hide emotions, especially for Japanese people compared to other cultures, but in this case, Japanese Americans still having a higher degree of feelings or expression of feelings restraint as compared to other American cultures. Thus, these cultural practices are practiced throughout the entirety of the lifespan of these differing cultural groups. And looking at specific health outcomes, that is looking at the impact of class on mortality. General health is also affected by different aspects of our cultural environments, such as class indicators like household incomes. Mortality rates are higher among lower-income Americans, and the pattern can be found in other industrialized countries as well as certain non-industrialized societies. So kind of just the idea that your household income, so one indicator of class, obviously impacts your mortality rates, and you can see this in the chart on your right-hand side. Income inequality. Subjective perceptions of health are also predictive of health. In other words, such a subjective experience of feeling poor matters. A sense of relative deprivation, that is, knowing others are doing better than you, may lead to stress and negative health consequences. There is something to be said about the health benefits of having some money in general, such as the countries that are on the left side of the scatter plot. It allows people to have access to life-sustaining cultural practices such as medication, but beyond a certain level, about 30,000 annual per capita GDP, objective wealth does not do a great job predicting life expectancy. This is particularly problematic in societies where there is great social inequality. The relationship between a country's Gini index, which is an index of income inequality, and an average life expectancy is negatively strong at negative 0.81. So kind of the idea here is, as stated, subjective perception of wealth having impact on health outcomes. The idea here is that, imagine living in an individualized society and kind of a meritocratic kind of capitalist society, wherein we're pursuing our individual goals, we're trying to accumulate money, and we're operating in a marketplace, in a kind of a competitive marketplace. Well, obviously there are going to be winners and losers within this competitive marketplace, and the idea with subjective perceptions of wealth is that even though you may be objectively more wealthy than an individual in another country, your understanding that other people are doing better than you could lead to stress and negative health consequences for a variety of reasons. One reason being that you may look at other people and say, okay, well, I'm obviously not a good person, or I'm not fulfilling my potential because look at me, I compared to these other people, they are much more wealthier than me. Therefore, this is kind of some personal indictment of myself. But there's also a potentially kind of bias in this data, wherein the most rich country in the world is the United States, where free medical care is not provided. So kind of having so an individual making less money in a different country, or even the same amount of money in a different country, will have a different country that has access to publicly available medical procedures, so whatever free healthcare or whatever free medicine, depending on the country. That will have an impact on health outcomes. So basically what I'm saying here is $30,000 in the United States is a different $30,000 than another country with public health care programs, because you're literally getting that for free. So your $30,000 goes a lot further in that context. Thus, it may be kind of presenting kind of a bias by this kind of gigantic outlier, the United States, kind of skewing the the relationship between objective and subjective wealth and kind of health outcome, or I should say subjective and objective wealth and health outcomes. But we also see kind of straightforward, kind of for obvious reasons, that up to, in this estimate of this study, $30,000, increasing the life expectancy of an individual, for obvious reasons. You have access to more medication, you're able to maybe eat better food, have better housing, etc. So kind of that combination of kind of life upgrades through this increase in yearly income and contributing to life expectancy. And interestingly, there is a relationship between, as I stated, the country's Gini index and average life expectancy. And Gini index is a kind of a measure of income inequality. So the higher the Gini index, the greater the income inequality within a country. And what this correlation means by negative correlation is that as the Gini index increases, again, a measure of social inequality, income inequality. So as income inequality increases, life expectancy decreases within a country, and that is a negative correlation. And then R equals 0.81 is a very strong correlation. Just giving a hint to the leading causes of death. The leading causes of death in preschool and school children are unintentional injuries, such as car accidents. Adolescence and early adulthood are car accidents, homicides, and suicides. 45 to 64 age group, cancers, and 65 years and older, heart disease. And this is within kind of a Western or United States samples. This would be different or a little different depending on the country and kind of the rates of child mortality and the higher rates of child mortality in low-income countries. The epidemiological paradox. Poor and racial minorities cross-culturally are at higher risk of adverse health outcomes. Not all disadvantaged minorities have adverse health situations, however. Latinos in the United States, for example. Researchers are not certain why. Although they tend to exercise less, Latino Americans tend to be less likely to drink and smoke than non-Latinos. There are cultural factors in Latino communities also contribute to relatively good health. High value placed on raising families, emotional support provided by family or community members, and unusually high levels of positive emotions. Paradox does not apply equally to all groups of Latinos, however. Puerto Ricans do not show some of the same unexplained health benefits as Mexican Americans. So, and I'll point this out in the next slide, but kind of the idea here is that in general and across cultures that racial minorities who have been historically disenfranchised and poor individuals overall having a higher risk for adverse health outcomes. However, in the Latino Americans, however, kind of do not have the same effect. And, well, more specifically, kind of some subcategories of Latino Americans, and this is known as the epidemiological paradox. And kind of the suspected reasons are that maybe these kind of social support, these and also kind of economic support, kind of this pooling these of resources, and kind of that, as stated, social, emotional, financial support, buffering the impacts of or protecting an individual or a group of individuals from the worst impacts of discrimination or higher rates of poverty within a country. However, as stated, it does not apply equally to all groups, with Puerto Ricans not showing some of the same unexplained health benefits as Mexican Americans. And that could be for a whole host of possible historical reasons, relating to possibly the history of Puerto Rico in the United States, wherein kind of Puerto Rico kind of till this day kind of not technically a colony because we don't say that word anymore, but kind of an unincorporated territory of the United States or incorporated territory of the United States, wherein that they do not have the same rights and social benefits as other states, or states I should say, within the United States, but kind of have a less sovereignty than other countries, such as Mexico, where Mexican Americans come from, and kind of that historical legacy of kind of a colonial occupation and less representation and kind of poor country overall is kind of reflected to this day, where it's just a high rate, the rates of poverty in Puerto Rico and the health outcomes and life expectancy in Puerto Rico is extremely low compared to the average of the United States. And again, that could be related to kind of a host of historical, political, and economic reasons that immigrants from other Latino countries experience less of. And here's just kind of a large chart that I grabbed. Kind of the idea here is comparing relative frequency of cause of death across 3 ethnic groups in the United States: Black Americans, White Americans, and Latino Americans. And you can see kind of compared to White Americans, Black Americans having much more being at a much higher risk factor for numerous causes of death. And then you look at the third column, Latinos versus European White Americans, and you see that White Americans have relatively higher risk for a whole host of illnesses, chronic illnesses. And again, kind of this is an example of the epidemiological paradox. The 5 stages of death. So this is kind of like this classic, what's really just known colloquially within our culture, the 5 stages of death, beginning with denial. And that is defense mechanism: anxiety-provoking thoughts are kept out of conscious awareness. Anger, why me? Bargaining, bargainer begs for some concession from God, the medical staff, or family members. Depression, so depression, despair, or sense of hopelessness becomes the predominant emotional response. And acceptance, accept the inevitability of death in a calm and peaceful manner. So kind of the idea here is that these stages of dying are stage-like. Each one, they go in a universal order, and at each stage, kind of like all stage theories, you unlock this new set of abilities, but in this case, a new set of grieving practices at each stage. Criticisms of the 5 stages of dying. Emotional responses to dying are not stage-like. The nature and course of an illness affects reactions to it. Individuals differ widely in their responses to death, and dying people focus on living, not just dying. So, as stated, emotional responses to death are not stage-like, so it's not this universal process where you go in those order of 1 to 5. Specific illnesses can impact the order in which you're working through those stages. And individuals just in general kind of vary widely. As we stated before, you can see it in grieving practices, but also kind of in the process of death. Cultures and individuals within particular cultures vary widely in their responses to death. And dying people do not only focus on those 5 stages of dying, but rather they focus on living and kind of trying to make the best of what finite time they have left. A study found that dying patients have goals: controlling dying, primarily by focusing on their chemotherapy and other treatments, but also, for some, by holding in the back of their mind the possibility of suicide if necessary. Valuing life in the present, getting the most out of the remaining time, even if they could no longer make long-term plans, and creating a living legacy, getting their affairs in order, creating good memories with their children, and touching other people's lives. So kind of the idea, as stated, was that when an individual is dying and kind of confronted with that certainty of death or high likelihood of death, individuals do not just focus on their dying, but kind of trying to live their life, and they have particular goals. As stated, this study controlling death, so kind of trying to prevent that high likelihood of death through various chemotherapies, but also having the understanding that they can still take control of their life one last time by having the either requesting active euthanasia or committing suicide if necessary, valuing their life as stated, so kind of making the social use of their time by spending time with their loved ones and trying to leave their loved ones with kind of the best memories possible. Perspectives on bereavement. Bereavement is defined as a state of loss. Grief is an emotional response to loss, and mourning is a culturally prescribed way of displaying reactions to death. The Parks Bowlby attachment model of bereavement should be familiar to you, Bowlby, other attachment models. They describe 4 prominent reactions to bereavement, which again is a state of loss. Numbness and a dazed sense of unreality and disbelief and almost empty of feelings. yearning, a time of acute separation anxiety, and efforts to reunite with the lost loved one. Disorganization and despair, as the realization of reunion with the loved one is seen as impossible. Depression, despair, and apathy predominate. And reorganization, invest less emotional energy in their attachment to their deceased and more to their attachment to the living. So kind of this is the idea, starting from the late 80s. And this is kind of a similar kind of stage-like process wherein kind of you're working through a sense of disbelief, and then finally at the last stage, reorganization, where you are where an individual devotes less time to their attachment to their deceased loved one and more to their attachment to their living loved ones. And then the chart is kind of or on the right is a chart from this study arguing on behalf of this theory of bereavement. Another model of bereavement is a dual process model of bereavement. This argues that bereaved individuals oscillate, that is, often unpredictably, between coping with the emotional blow of the loss and coping with practical challenges of the living. There's loss-oriented coping, involves dealing with one's emotion and reconciling oneself of the loss, and restoration-oriented coping. They focus on managing daily life, rethinking one's life, mastering new roles, and challenges that come following the loss of a loved one. Over time, the emphasis shifts from loss-oriented to restoration-oriented coping. It's also seen at the family level, for example, following a child's death. So kind of the idea here is that there's dual process, that we have this loss-oriented and restoration-oriented styles of coping, and individuals bounce back and forth in the process of bereavement. But not just individuals, but also kind of at this family unit, so at larger social unit levels that also bounce back and forth between loss-oriented and restoration-oriented coping styles within their everyday lives. Thus, it's not really this kind of stage-like process, but kind of this dynamic process where you kind of bounce back and forth between those two types of coping styles, depending on various environmental factors at an individual level and, as stated, at a family level. Infants' conceptualizations of death. Infants do not grasp death as cessation of life. They may grasp the concepts of being and non-being. Bowlby argues for three phases: protest, yearning and searching for the loved one, expressing outrage when they fail; despair, displaying depression-like symptoms; loss of hope, the child ending their search for the loss of loved one and becoming sad; and detachment, takes renewed interest in toys and companions. Infants recover most when they can rely on existing attachment figure or can attach to someone who is sensitive to and responsive. So kind of the idea here is that kind of like similar parts of development, infants and individuals in general respond to trauma when they can rely on buffering effects from other individuals, but as we talked about throughout this course, other community and kind of countrywide macro buffers. But in this case here, for an infant, not really concerned about the macro economics of a country, they rely on an existing attachment figure or can attach to someone else who is sensitive and responsive to their needs, to buffer those negative effects associated with the death of a loved one. Moving on to young children. Young children are highly curious about death. They think about it with some frequency. They build it into their play, and they can talk about it. Mature understanding of death in Western culture. Finality. It is a cessation of life of all life processes. Irreversibility, it cannot be undone. Universality, it is inevitable and happens to all living beings. And biological causality, that is, it is a result of natural processes, even if external causes set off these internal changes. So again, this is obviously within a Western culture and discounting other cultural variations that we'll cover shortly. But the idea here that this Western culture, kind of secular understanding of death, wherein young children are able to recognize within these particular cultural constraints that death is final, irreversible, universal, and has a biological or is caused by biological outcomes, even if external events contributed or directly caused the internal changes within a dying person's biology. And basically all that means is that, imagine a giant rock falling on my head and like killing me. That external stimuli, the giant rock falling on me, crushed my heart or something along those lines, and that's so the rock caused an internal biological damage to me, which led to my death. Grasping the concept of death, children's understanding of death is influenced by cognitive development. Piaget argued the concrete operational stage allowed children to better understand death. That is, when children are acquiring logical operations, it can reason effectively about real objects and experiences. Cultural experiences. Cultures differ on how much parents should protect children from the idea of death. And life experiences. Children who have had personal experience with a death in their immediate extended family often have more mature understandings of death. So children's understanding of death, as I stated, you have this Piaget argument wherein a child has to be able to reason logically and work kind of through kind of cause and effects of objects interacting with each other, thus being able to understand kind of death. Cultural experiences impacts children's understanding of death because the conceptualizations of death vary by culture, and kind of the willingness to talk about death varies by culture. That's talked about kind of opening slides, the Ares argument of Western societies kind of moving away from confronting death. And life experiences, so children who are exposed to death early on in life will have obviously a more mature or a fuller understanding of what death is, or more likely to, I should say, have a full understanding of what death is compared to children who just either have talked about it or have not talked about it with their parents and just have never experienced it themselves. Or I should say kind of given within their family or immediate social circle. Children ages 5 to 7 understand death is final. Researchers argue that adults make death more confusing and frightening to young children when they use euphemisms such as gone away and asleep, and it is recommended to give simple but honest answers. So kind of the idea here is that children have a more full understanding than what parents typically, or some parents give them credit for, of the understanding of death, and are thus capable of having, semi-reasonable, within the confines of 5 to 7 year olds, conversations about death, and often kind of giving these metaphorical euphemisms can contribute to more confusion and scared reactions to death. Thus, researchers recommend in general to give simple but honest answers, but obviously considering kind of the developmental, or I should say kind of like the developmental, the stage of development, the social skills, the cognitive skills, the buffering available to the child. So kind of considering all those kind of things, individual development of a child alongside kind of this understanding that children understand death at a higher level than what a lot of adults give them credit for. The dying child. Dying children are more aware of what is happening to them than adults realize. Preschool children understand death is irreversible. They experience many of the emotions that dying adults experience, avoid talking about it, or have open anxiety, need a strong sense that their parents are there to care for them, and it is recommended to follow the child's lead, enabling children to talk about their feelings and answering questions simply and directly. So kind of as stated before, instead of kind of using those euphemisms, recognizing that the child is capable of understanding death and that they kind of are capable of kind of directing conversation, but within reason, obviously, while at the same time kind of offering supports and kind of making it clear that parents or the caregivers or the loved ones care about the dying child. The bereaved child. Children grieve, express their grief differently than adults, and they lack some of the coping resources of adults. Some children are vulnerable to long-term negative effects of bereavement. A longitudinal study of school-aged children found 1 in 5 who lost a parent had serious adjustment problems 2 years after death. Most bereaved children are resilient and adapt. 2 to 5 years after loss, children who have experienced death of a parent typically look like non-bereaved children in socio-emotional and academic functioning. Children fare best when their caregiver maintains their own mental health, has a secure relationship with their child, and provides good parenting. So the idea here is that the majority of children who lose a parent do not have serious adjustment problems 2 years after death. However, children fare best and are most resilient when they are able to, or when they have parents in kind of social circumstances where they have strong attachments or attachments that are common within that culture. The caregivers are able to maintain their own mental health because a parent who becomes depressed themselves following the loss of a spouse, it's not super unexpected, or it's definitely possible and are at risk of doing so. Typical characteristics of depression, kind of distracted by your own pain and grieving process, thus kind of reducing your ability to be a responsive, reciprocal parenting style or having reciprocal parenting practices. Preschoolers grieve, but they have problems with sleeping, eating, toileting, and other daily routines. Older children's grief, they express directly, and somatic symptoms such as headaches are also common. Advanced understandings of death. Adolescents typically understand death as the irreversible cessation of biological processes. They use their new cognitive capacities to ponder the meaning of death. Some think that psychological functioning such as knowing, believing, and feeling continue. Among adolescents who adopt the belief that the spirit or soul lives on after death does not mean that they are giving up biological understanding of death. These adolescents call upon both as needed, depending on the situation and what they are trying to explain. The argument here then is that adolescents have higher cognitive capacities than younger children, and their understanding or the way that they could characterize death in spiritual or non-spiritual terms does not necessarily mean that they do not understand kind of or have a biological understanding of what death is, but rather that they kind of use those explanations as needed. If they are spiritual or kind of have some religious background, and they use both explanations as needed. Depending on who they're talking to, what the situation is. How they're kind of having to express to others what happened to their parents, for example, or how they're kind of processing death on an individual or even a family level or community level for that matter. Adolescent reactions to becoming terminally ill are likely to reflect the themes of adolescence: concerns with body image, wanting to be accepted by peers, and distress by having to depend on parents. So kind of in a Western setting, these are similar kind of trends of autonomy to development within adolescence, and those themes are maintained even in the process of dying. But obviously, when you have a chronic illness, you're more likely to have higher needs and dependency on your parents, and that kind of dampening that your ability to be an autonomous individual within a Western context. And then obviously you still want to be accepted by your peers within your school or your neighborhood, etc. Losing a parent also reflects the themes of adolescence. They're reluctant to express grief, they may engage in delinquent behavior, and they have somatic ailments. Reactions to death of a parent: 30% experience significant grief reactions in the first year following the death of a parent, 10% 3 years later, and the rest experience mild grief. More likely to suffer major depression, alcohol abuse, and PTSD in the first year following the death of a parent. So, kind of as stated, adolescents their themes of adolescence follow them through the process of death, in this case, the death of parents, where they are at most at risk during the first year of following the death of a parent, and kind of with time, a decrease of the most severe reactions to the death of a parent. But even in the first year, the majority of adolescents following the death of their parent do not experience significant grief reactions, or at least grief reactions that are kind of antisocial in nature or kind of self-harming grieving processes. Some studies have found that cortisol levels are higher in bereaved youth compared to non-bereaved youth. Bereaved youth are less likely to have close attachment to peers, have more difficulties at work, have lower educational aspirations, and less developed career plans. Outcomes are worse for those who blame others for their death, had low self-esteem, used negative coping strategies, and had a caregiver who was severely depressed. So bereaved youth are at risk for having more difficulties at work or in school settings, and that can leak over to their long-term academic or job plans. But outcomes or negative outcomes following from bereavement are associated plainly stated, the most at-risk bereaved youth are those who already had kind of prior self-esteem issues, at least in the United States, used negative coping strategies, and as stated before, having a caregiver who was severely depressed. So kind of that lack of buffering that a parent or a caregiver or a family can provide. And that is really necessary for children to positively process the loss of a parent, or at least is the presence of those buffers increases the likelihood that they will positively, or at least not negatively, have negative outcomes associated with or long-term negative outcomes associated with the death of their parent. Death in the family context in adulthood. The loss of a spouse or partner often precipitates the need to move, entering the labor force or change jobs, assuming responsibilities that the partner formerly performed, parenting single-handedly, and coping with less money. So the loss of a spouse obviously contributes to a whole host of new stressors, obviously the loss of a spouse, that emotional damage from that, but also kind of the need to possibly move, re-enter the labor force, assume additional parenting responsibilities, and at the same time having that loss of income. And as we talked about in the last chapter, those dual income family households, the norm within the United States. So kind of the loss of that income, the loss of your partner, more responsibilities, and still trying to kind of maintain some level of responsiveness to the child to help them kind of buffer through their grieving process. And I want to outline two types of griefs in adulthood: disenfranchised grief, and that is grief that is not fully recognized or appreciated by other people and therefore may not receive much sympathy and support; and complicated grief, grief that is unusually prolonged or intense and that impairs functioning. About 15% of adults, and is recognized by the DSM-5. What is viewed as complicated grief varies across culture. So disenfranchisement grief, this can be something like neglect of buffering from other loved ones in the grieving process, or not just immediate loved ones, but just kind of maybe community level, or at the community level, at a family level, at a peer level, kind of just being neglected or ignored, or just really not offering much support. And complicated grief, as I stated, recognized by DSM-5, but it's important to keep in mind that the grieving processes are different across culture. So what may look like a complicated grief, this prolonged, intense grieving process in one culture, may be the norm in another culture, and thus not signs of a psychological condition. The loss of a child seems unexpected, untimely, and unfair. Parents are often unable to make sense of a child's death. The age of the child who dies has little effect on the severity of the grief. Siblings also grieve, but may not have support from parents. A study found that only 12% of parents whose young adult child died of an accident, suicide, or homicide said they found meaning a year later, 57% 5 years later. Outcomes on marriages are likely to be worse if the marriage was unstable before the death of a child. So typically across cultures, there's different views on death, and the death of loss of a child is treated differently than the death of a grandparent or an older adult, for example. And in this case, one study found that parents find little meaning in the death of their child, especially during the first 5 years of their child's death. And even 5 years later, a solid majority, or slim majority, I should say, 57% finding meaning in their child's death. Outcomes of and the impacts on marriage differ, and those who are already in rocky relationships, unstable relationships, are more likely to become worse following the death of a child. And that's kind of consistent with what we've seen across developmental outcomes in this course. So in general, parents view the loss of a child as unexpected, untimely, unfair. Child dying young, or young, to a parent, the child is always going to die young. And thus contributing to meaning, finding meaning within that death, or really making sense of the child's death. The grief work perspective. The views that to cope adaptively with death, bereaved people must confront their loss, experience painful emotions and work through those emotions, move towards a detachment from the deceased. It's derived from the legacy of the Freudian psychoanalytic theory held widely in our society, or widely. So kind of the idea, as stated, you have to work through these 3 stages, and that's the only way you can grieve properly and then get back to work or going back to your daily life. So, and this is kind of from, as stated, kind of a Freudian analytic, psychoanalytic view, and this is kind of widely seen in our society. You see this in all kinds of cultural movies, TV shows, or just typical thought that you have to confront your loss, then you have to process it, and then you have to detach from the deceased loved one. Criticisms of this model. Cross-cultural studies find that there are many ways to grieve, and the model thus may be culturally biased. There is little support for the assumption that the bereaved individuals must confront their loss and experience painful emotions, and there is no support for the view that we must break our bonds. Bereavement rituals in some cultures are designed to ensure a continued bond between the living and the dead. As we reviewed in the previous slides, there is no cross-cultural universal way that people grieve. And there's little support or to no support for the idea that we have to confront the loss and have to feel painful. And that then after feeling that intense pain, then we have to just move on from that person for the rest of our lives and have this strict demarcation between living and death. That is not supported universally, and frankly, not even in the United States, within cultures found within the United States universally. It's many cultures are designed to ensure that there's a bond between the living and the dead, and some kind of memorial or kind of ritual or daily reminders even of connection to people or loved ones that have died. Coping with bereaved individuals is influenced by individuals' personal resources, that is their coping style, and the secure attachment associated with coping relatively well after death, nature of the loss, of violent deaths, child's deaths are harder to cope with, and the surrounding context of collectivist support and stressors. Social supports aids in coping, additional life stressors harm coping. Siblings can help each other cope, adult children can help widowed parents. Bereaved individuals report they are most helped when they are allowed to express painful feelings freely, if and when they choose, rather than trying to cheer them up and talk them out of their grief. So individual and kind of community resources impacting the ability or the success rate of an individual coping with bereavement, with coping styles and secure attachment to other relationships being associated with coping relatively well, and also kind of social support from your family, and in the case of for example, a parent dying and there being 2 siblings, for example, one of the siblings or both of the siblings kind of supporting each other, helping them cope with the stress following their death. And kind of the idea here is that allowing bereaved individuals to talk kind of on their own terms and kind of work their way through it and talk about it without having this idea that, okay, you have to process this and now you have to be happy kind of thing. And again, this kind of goes back to that idea of the grief work perspective, wherein something has happened to you and now you have to get over it, or it's kind of a bad reflection on you that now you're not happy anymore. And in fact, by you not being happy, you're harming yourself and other people. And I want to briefly just mention this Barbara Ehrenreich book, Bright-Sided. And basically what happens is that she gets diagnosed with breast cancer and was not a drinker, really didn't do any drugs or anything like that. And what she found was, she was pissed off about that, obviously. She was angry. And then when she went kind of looking at support groups, and she's a professor, and I'm not sure if she's still an active professor, but kind of out of academia. And she was kind of trying to do just some research on kind of self-help groups or kind of just support groups in general. And basically what she found was that kind of expressing any form of negativity or hostility or anger at the diagnosis was really frowned upon and thought to kind of be a selfish action that was contributing to the progression of cancer and harming other people around them. So, the idea here is that your internal state, your internal emotions impacting the development of cancer, causing your chronic condition. And she kind of going through the history of that idea of the need and the necessity of feeling happiness, or the idea that the happiness internally contributes to this external world where you're kind of literally manipulating the external world through your internal emotions. But long story short, kind of just an example of this idea that bereaved individuals want to work through and express their painful feelings and not be told that they have to cheer up, or they're just like ruining the vibes of the moment because they have a cancer diagnosis. Post-traumatic growth. Bereavement can have positive consequences. Post-traumatic growth, positive psychological change resulting from highly challenging experiences such as being diagnosed with a life-threatening illness or losing a loved one. Growth seems more likely when distress is significant but not crushing. So the idea here is, if a bereaved person wants to participate in kind of this growth idea of improvement, again, not necessarily they want to and they don't have to, that's not kind of a poor reflection on them, that a cancer person would rather be angry than kind of do this inspirational story routine. But kind of if they choose to participate that, they can find positive psychological changes as long as the bereavement isn't a kind of complete crushing of the psychological spirit of an individual. Hospice, a program that supports dying people and their family through a philosophy of caring rather than, quote, curing. Part of the palliative care movement, aimed primarily at bringing comfort to and meeting the physical, psychological, and spiritual needs of parents or of patients with serious illnesses. So kind of the idea here is that rather than just seeking a cure and keeping a person alive at no matter the cost and no matter how poor the quality of life is, hospice care and kind of the palliative care in general kind of aims to bring comfort to individuals in their kind of dying process in their final days, months, years, or whatever within their lives, and kind of meeting their psychological, physical, and spiritual needs during that process. So the idea here again is kind of caring rather than trying to keep an individual alive at all costs, and kind of challenges the idea of health and the body in health in the United States, as we talked about before, that metaphor of a machine, this asocial machine, wherein you just replace the body part and you keep rolling. And then also kind of confronting the idea of that critique that Western societies kind of avoids death at all cost, and this providing more of a care interpersonal dynamic during the dying stage of development. The dying person and his family, not the, quote, experts, decide what support they want and need. Attempts to cure the patient or prolong his life are de-emphasized, but death isn't hurried either. Pain control is emphasized. The setting for care is as normal as possible. Bereavement counseling is provided to the family before and after death. Studies suggest the relatives of dying people rate their quality of death experience more positively and display fewer symptoms of grief and have a greater sense of well-being 1 to 2 years after death than those who do not receive hospice care. So as I said in the previous slide, the idea here is that trying to make this process as kind of inclusive as possible, kind of bringing in families and taking this more kind of holistic approach to death, wherein the setting is as normal as possible, maybe in a home setting, ideally, and controlling pain is emphasized to try to kind of maximize the quality of the remaining days for an individual. And studies kind of support the idea that individuals who or families that kind of go through this hospice care procedure, this approach, stages hospice care approach, rate their quality of death experience more positively and display fewer symptoms of grief than those who choose not to receive hospice care. Most bereaved individuals do not need psychological intervention to cope. Those at risk for complicated grief can benefit from cognitive behavioral therapy, family therapy, public health programs, and kind of just addressing kind of the root causes that we've talked about before of inequality, and that could be racial discrimination or income and kind of wealth inequality. And to wrap up the themes of the text, nature and nurture interact in development. We are whole people throughout the lifespan. The development proceeds in multiple directions. There's both continuity and discontinuity in development. There is much plasticity in development. Historical context. We are active in our own development. Development is a lifelong process, and development is best viewed from multiple perspectives. With that said, thank you so much for everyone, for all your hard work this semester. I really appreciate it. I hope this our time together challenged your belief or your understandings of psychology to kind of include these larger contextual factors and present to you kind of information from other cultural contexts and historical era that really sheds light on the impact of those historical factors on human development. So again, thank you so much. I appreciate all your hard work, and have a great break. And if you ever need anything, feel free to reach out to me even after our time in this class is over. And thank you so much. Bye.